So thank you for having me. My name is Dr. Michael Verbora. I'm a family physician. I work at a clinic called the Cannabinoid Medical Clinic, and we take referrals only from specialist colleagues and family doctors if they feel like medical cannabis might be an option for a patient's therapy. In terms of my disclosures, I do a number of talks, given this is a new topic, and I have received honorary in the past as well as one for today. I also have a faculty appointment at McMaster. In terms of mitigating potential bias, these slides were designed by myself, and the reality is herbal cannabis does not have any indications, and it is completely off-label, and Health Canada has really been forced to comply with the court system because patients have used the court system to gain access to cannabis. So the government's been forced to come out with a medical cannabis regime strictly based on the legal system. Cannabis does not have a DIN number. In terms of learning objectives, I have 3 objectives for today. So one, I want to hopefully have the people in the room understand the different medical products available to patients, understand the system that is legal to patients, understand the potential conditions and benefits that patients with cancers may receive from medical cannabis, and then develop a safe approach to prescribing cannabis. I'm not going to be discussing Nabilone or Sativex today. Those are synthetic cannabinoids that are available. Those are other options as well that can augment the endocannabinoid system. Okay, so to address this, I'm going to go through a number of cases. So the first case I want to talk about is Susie. She's a 75-year-old female with neuropathic pain, which was unfortunately uncovered after undergoing chemotherapy. And she states that overall her cancer is stable and she's in remission. She's had worsening pain in both her upper and lower extremities, and she has typical neuropathic symptoms. She's been on all the typical neuropathic agents for this type of pain. She's still now only on Cymbalta. She had to stop the other ones due to side effects. And so she was referred to us from her pain specialist, wondering if medical cannabis could be of use for her pain, her neuropathic pain specifically. The second patient is Maggie, and she's dealing with insomnia. She's a young lady, 30 years old, and she's had cervical cancer. She's been treated surgically, and she's been deemed in remission. Otherwise, she's relatively healthy, and she's been dealing with chronic insomnia since her diagnosis of cancer. She also has a lot of anxiety and fear around the recurrence. She has tried, sleep hygiene and cognitive behavioral for sleep. That didn't really work well for her, unfortunately. She's been on a number of medications such as Zopiclone, Ativan, and Remeron for sleep, but these are all causing side effects, and she tends to report that she has that zombie feeling the next day with Zopiclone. So she's referred to us wondering from her family doctor, can medical cannabis help with her sleep? And the last patient is Rebecca, and she has ovarian cancer, and she's a 65-year-old female, stage 4. Unfortunately, she's inoperable. She's deemed palliative at this time, and she has bony mets causing pain, insomnia related to her pain, anxiety, appetite suppression, nausea, typical palliative symptoms. Her current medications are listed there, which include opiates and sleeping pills, and she's also on a synthetic one called Nabilone, a cannabinoid medication. She's using that at night off-label for sleep. So she comes to me and she's asking, can I use cannabis to help with my symptoms? And I also researched online it can help my cancer or cure my cancer. So can you help me, doctor? So those are the 3 cases that we're going to get to, and I'm going to come back to those at the end. So first I want to dive into cannabis, and I'm going to start with a question. So the endocannabinoid system, is it A, found in every organ in the body, B, limited to our nervous system, C, well represented in the brainstem, D, responsible for a fight or flight response, or E, clearly defined in its function? Okay, so mix of response, but the answer was A. So it is found virtually in every organ system in the body. So a little bit about the endocannabinoid system. I don't know about you, but I graduated residency just 3 years ago and medical school in 2013, and I was never taught about an endocannabinoid system. Has anybody else had that experience? So the endocannabinoid system is actually a critically important system in our body. And so I don't think we're getting an accurate picture of our full health unless we understand this system. And just because we don't fully understand it doesn't mean we shouldn't be educated on it. We should educate ourselves up to the knowledge that we have. And so the reality is that this endocannabinoid system in our body is a highly preserved system found in nature. And so even nematodes have endocannabinoid systems. And the reality is you cannot survive without an endocannabinoid system. So we know to date that the endocannabinoid system is typically involved in homeostasis. This is the system that regulates systems, and it is involved in our immune function, our sleep, our pain perception, bone development, memory, cardiovascular function, digestion, and more. And there is plenty of basic science research out there to show how vital of a system this is. And when we run or we do yoga or we meditate and we can feel that sense of well-being and calm, and sometimes you can even generate euphoria from these experiences, that is endogenous production of your own cannabinoids. So your body is synthesizing endogenous cannabinoids and you're feeling relaxed and calm. And of course, there's phytocannabinoids in the plant, medical cannabis or recreational cannabis, that augment your body's own cannabinoid system. The nice thing about the cannabinoid system is that while it is in virtually all the organs in the body, the one area of the brain that the endocannabinoid system is not involved in is the brainstem. And that's really, really important because despite people taking high doses, you will not have respiratory depression because that's where the respiratory centers are in the brainstem. And this is substantially different when we compare it to other drugs such as benzodiazepines and opiates, which many of my patients are referred to me on and kill 4,000 people a year in Canada and 22,000 people last year in America. So the reality is because the receptors CB1 and CB2 are not in the brainstem, it is considered a safer medication relative to the drugs that operate on the brainstem. When we look at the medical cannabis plant, we have to understand why it's so complicated and so difficult to study. And the reality is that there are over 500 ingredients in every single cannabis flower that you would look at. There's 3 layers of ingredients, and I've listed them there in terms of importance. So the first layer is phytocannabinoids, and I think many of us have heard of THC and CBD, but the reality is there's over 70, probably closer to 100 phytocannabinoids. And we're going to slowly start to isolate these and understand how each of these cannabinoids may have medicinal benefits. And then the next layer of ingredients is called terpenes, and these are naturally occurring ingredients that we see in plants, fruits, vegetables. So things like limonene, which is found in lemon or oranges, and things like linalool, which is found in lavender. They have medicinal effects as well, but when used with cannabinoids might have a synergistic effect. And then there's flavonoids, which add flavors and aromas. They're not as medicinal, but this is why that's so complex, because you can imagine the genetic diversity in the cannabis plant. When you combine all of these ingredients in huge different permutations, you can have hundreds and thousands of different strains, and that plays to the effect that patients state that one strain will give them energy and another strain will be sedating. So what's happening there is that there's different genetics at play and there's different ingredients in the strains. So the 2 most popular phytocannabinoids are the ones that we know the most are THC and CBD. And the reality is, despite that complexity, the plant makes and takes its energy and makes these 2 ingredients typically in the highest concentrations, and these are the most medicinal ingredients in the plant. So THC is the one I think most of us are familiar with. It is psychoactive. It can cause a high or euphoria, which we can debate if that's medicinal or not. It can help with things like muscle spasms, anxiety, insomnia, poor appetite, nausea, neuropathic pain, or mood. But again, this is probably relative to the dose that people are taking. In rare circumstances, this is the ingredient that does cause psychosis. On the other hand, the yin to the yang would be CBD. CBD is a very, very interesting ingredient. It is not psychoactive. You cannot get high or euphoric from this ingredient, but it has anti-inflammatory properties. It works on pro-inflammatory molecules in the immune system. It can help with muscle spasms, nausea, and epilepsy as well. It is currently being studied for a number of different conditions, but we are way too early to claim benefit for CBD in a lot of these conditions. The World Health Organization, if you're interested in learning about CBD, the World Health Organization put out a big report earlier this year talking about how safe of a medicine this is. And their argument was that this should not be a Schedule I drug in the United States, which is limiting our ability to research and access it. So there is this idea in the literature that while traditionally we take plants, we find medicinal ingredients, we isolate them, or we synthesize different ingredients from that medicinal ingredient and study it, which is great for science and easy for us to study one ingredient at a specific dose. The reality is many people feel that if we do this with a cannabis plant, we're going to lose some of its effect. There's this thought that there's an entourage effect, and the reality is that maybe we need all of the phytocannabinoids, maybe we need all the terpenes in certain combinations to get the right medicinal effect. And anecdotally, I can tell you, as somebody who prescribes a lot of nabilone, I do find that a lot of patients report more side effects with the synthetic form of cannabinoids. So we don't really know if this is accurate or inaccurate, and I still think we're going to have pharmaceuticalization of cannabinoids regardless. But the reality is there's going to be a huge market or a number of patients that still want the natural plant. And there may be some science to their benefit that they're reporting. Okay, so I'm going to dive into some of the medical evidence, and we're going to go to a question. The following has medical evidence, except, so multiple sclerosis spasticity, nausea and vomiting related to chemo, anxiety and depression, chronic neuropathic pain, or opiate-sparing effects. So what we're looking for is the answer that was false in this question. So everybody's quite spread out, which is good. So obviously there's a lot of controversy when it comes to the evidence. Based on a systematic review, which I'll quickly show you, the one condition out of those 5 that we listed that has very little evidence supporting it would actually be anxiety and depression. So despite the fact that 70% of my patients come in and tell me that cannabis helps with anxiety, the reality is there's still not good evidence to support it. And there is actually evidence in recreational users that the use of THC specifically causes anxiety. But what I feel like is it's really based on the dose. And the problem is that we're looking at recreational user studies who are smoking cannabis, using a lot of fast acting and using a lot of THC, who are having rebound anxiety. So I do believe, and I have seen thousands of times, that cannabis can help with anxiety, but the data doesn't match that yet. The other conditions have at least mild to moderate evidence. So what is the problem with getting evidence around cannabis? So there's a number of biases that I think we have to be cognizant of. And the reality is first there's an access bias. So in the States, this is a Schedule I drug, and it's controlled by the DEA, and their entire mission is to enforce drugs. So they get paid to not have things be legal, essentially. So it's a little bit of a conflict of interest. And the reality is the only studies that they've funded over the last 20 and 30 years are outcomes that look for negatives. So if you wanted to study a potential positive of cannabis, you really weren't given money to do so. That's changing rapidly, and I think Canada is going to lead in this front given our new system. But that's just the reality of the current state of the evidence, is that 90% of the research has their primary outcome is a negative outcome. And that's not really balanced, especially when so many people claim medicinal benefit. And then there's also selection bias. So we talked about, for example, the anxiety. The reality is a lot of people take the data from recreational users or young people that already have mental health conditions who are using cannabis to cope, and then they take their outcomes and extrapolate that somehow and say that medical users are like that. And those are 2 totally different populations. So I don't think we can extrapolate from recreational users who already have pre-existing conditions and say that that's going to happen to medical users. That's not accurate. And the last thing is confirmation bias, and I have seen this slowly shift, having given presentations for the last 3 to 4 years now. The overall attitudes have slowly been shifting. I think we've seen a lot of anecdote, and I think we've seen a lot of observations in our offices with patients perhaps doing better with cannabis and seeing typically not too many harms. So the reality is a lot of us still have a confirmation bias. We've really been told that cannabis is a bad thing for us. It's not a medicine. It can cause a lot of problems. So to confront those biases in and of itself is something that we have to slowly see change over time. So this is the systematic review that I wanted to briefly talk about. So it's a 400-page document, but if you just read the first 30 pages, you'll get the 30 conclusions that they came up with. So this reviewed all the literature, essentially. It was funded by, I think, the Arizona State Department. And there's a number of different experts that were involved on it. But if you are really interested in understanding the current state of evidence and if it's moderate, conclusive, substantial, this is how they graded it. So I'm only going to show you the positives of this, and I'm going to briefly talk about the negatives later in the presentation. But the positives were that overall cannabis has conclusive evidence for 3 conditions at least: chronic pain, and specifically neuropathic pain has even better evidence within that, MS-related spasticity, and chemotherapy-induced nausea and vomiting. And the other thing is this included not just dried flower herbal cannabis. This also includes synthetic cannabinoids like Sativex or Nabilone as well, or dronabinol, which was used in the States. So all these studies are looking at all of those different drugs together. There is some moderate evidence for insomnia with certain patients with certain conditions. I would say that these conditions probably make up 80% of the patients that I see in my clinic. And there's another 20% that fall outside that, but typically they have, treatment-resistant conditions, a lot of rare disorders, or they're palliative as well. And so, our goals are slightly different, and perhaps the evidence doesn't need to be there to help some of these patients that really feel like there's nothing else to use. Okay, so the methods of consumption of medical cannabis. So when I first started, I was actually being educated and taught by my patients in reality. And I still feel like some of us are still being taught and educated by patients, and that puts us in an uncomfortable position because we're supposed to be the expert. And then so, we can roll our eyes sometimes about that. But the reality is patients have been using this for a number of years. They use all sorts of forms, but the 2 forms as a physician that I authorize or prescribe are ingestion or vaporizing. Patients may choose to use their cannabis in other ways, and the courts have said that if they have access to it, they're allowed to transform it into any form that they want. But I only suggest those 2 forms because I have a sense of control and science over it. So the 2 routes of delivery are the lungs and the gut. So inhalation works extremely fast. So it's a very fast-acting method. Goes right from the lungs into the bloodstream, works rather fast, maybe 10 to 30 minutes, and the peaks rather quickly, and it can last about 2 to 3 hours. There's very, very minimal metabolism, but it does happen. And then this is a way to rapidly deliver a dose of medicine. And it'll be interesting to see if we use the lungs for other medications in the future, because currently we really only use puffers and I think medical cannabis. But I wonder if the lungs are a viable option with all the pharmaceuticals and drugs that so many patients are on, and all the metabolism that takes place in the liver and the kidneys. When I have clinical pharmacologists in my clinic shadowing, many of them have taught me that, look, a lot of these drugs aren't actually getting absorbed because there's patients on 20 pills. So who knows if the Lyrica and the gabapentin and the Cymbalta are really working, or which one's actually getting there because of the limited enzymes. There is some bioavailability factors there, depending on how you hold your breath and such, but it's pretty minimal. The difference between smoking and vaporizing, so I never recommend any patients smoke cannabis. The reality is that systematic review at the beginning, they couldn't draw a conclusion that smoking cannabis led to increase in cancers, and they couldn't draw a conclusion that it led to lung disease. But I have seen anecdotally young people who've only exclusively smoked cannabis in their 40s develop COPD. So while the evidence isn't there, I do not recommend it. I just think it's a matter of time and common sense that we're going to find that smoking cannabis causes lung disease and other problems. And it's probably not the cannabis flower itself, it's just the act of smoking, combustion. So there is no real benefit to smoking, and I do a lot of education with patients. A lot of patients come in already smoking cannabis, and I try to convert them to longer acting modalities such as oils or vaporizing. And the reality is that it's economically beneficial as well, because you're not wasting any cannabis. None of it's going up in smoke. And you still get all the same medicinal effects. When it comes to ingestion, the cannabis in the raw form is not active. So you could eat raw cannabis and you're not going to get any psychoactive effect or any medicinal effect, really, at least as far as we understand. The reality is it has to be heated, and so that's why people smoke it or vaporize it. It has to get above a certain temperature so the acid forms of the cannabinoids convert to decarboxylated forms, and that's when it's activated. So the same goes with ingestion. You can't just eat the raw form. It has to be heated, whether that's in an oven or a fancy company's machine that extracts it at a high temperature. And metabolism of THC and CBD both take place in the liver, and the THC gets converted to, how do I go back here? Oh, there we go. The THC gets converted to 11-hydroxy-THC, and that's actually slightly more psychoactive than the THC itself. So you have to be really, really careful. I just read a report in Vancouver's 420 recreational marijuana protest day, and the reality is there's the article said 130 overdoses of marijuana. And by overdose, they really mean adverse effects, because you can't overdose on cannabis. All of them were exclusively from eating edibles, so ingestion. You won't typically get that with inhaling. So that's the conversion that takes place, and those are the enzymes that are responsible. I don't believe there are substantial drug interactions, but the reality is we don't have a lot of data on this. The worst interactions I see are with anti-epileptics and using CBD. And so we have ways around prescribing CBD to avoid interactions. In terms of ingestion, you can get increased sedation or euphoria because of the 11-hydroxy-THC, and there is a huge amount of interpatient variability that are listed there. The onset for ingestion is much longer, and it can last 5 to 8 hours. So this is a longer form of use of cannabis. And if you look at the pharmacokinetics, this is just a graphic representation of essentially how fast the medication will work and its peak concentrations. Okay, so I'm going to shift to the legal licensed producer system in Canada, give you a sense of what's going on there. So the reality is, if you want to distribute cannabis, you have to apply to be a company, and you need millions and millions of dollars to apply to Health Canada, and Health Canada has to approve you to grow it, they have to approve you to sell it, they have to approve you to get oils, they have to approve you to sell oils. And it's extremely tightly regulated system. You have to store all the cannabis in, $100,000 vaults. It's kind of interesting that we do all of this with a plant. We don't do this with fentanyl. Way easier to prescribe fentanyl than it is cannabis, I could tell you. Something's wrong there. So nonetheless, once you're approved by Health Canada to be a licensed producer, you can have a physician authorize. Technically, the term is authorize, not prescribe, cannabis. And I'll teach you a little bit about what an authorization looks like. And then the patient would get access to that, and they would go to one company, and they would get the products from that one company online or through the phone, and then it would get mailed to them. So there's a little bit of a lag time, and it's really unfortunate because I do work with sick kids and see a lot of palliative sick children, and I've been in situations where the children are passing away because it's taking too long to get the cannabis there. So it's a really unfortunate system. That needs to change, and I'm definitely advocating in that front. If you look at the products that are available, the dried flower and the oils are the two products that are typically available, but we're going to see more products such as dissolvable films or faster acting ingestibles, maybe patches, and there's also some companies that are coming out with creams. I have no idea if the creams work. There's like literally zero evidence for it, but there's also zero harm to use it, so it's one of those pieces of advice I give patients. If you want to try it, go for it, but I just don't know if it's going to work. And the reality is this probably needs to be combined with pharmaceuticals to actually penetrate the tissues. I think superficial treatment of things like inflammatory conditions don't really work with cannabinoids, but that's just my opinion. There's no evidence to support pro or con for topicals. Nonetheless, products are going to come out, they're going to advance, and they're going to advance faster than the science can catch up with. So I'm going to try to simplify the different cannabis products, which is not easy. So there are hundreds of strains available, and patients can report so many different benefits or side effects from each of these strains. But the reality is we can kind of divide them into two different areas. We can divide them into oils, so long-acting, and dried herb, which is flower, which is going to be short-acting and inhaled. And the reason why they're in oils is just because it's fat-soluble. So if you just consume the raw cannabis or you heat the cannabis and eat it, you may get an effect, but consuming it with oil will increase its absorption and bioavailability. And then you can divide each of these, the flowers or the oils, into CBD-dominant, THC-dominant, or a hybrid, which is essentially CBD and THC. And the reality is the plant will take its energy and it will choose one of those three essentially. So those are the three phenotypes that we typically see. Either the plant's going to take its energy and make a pure CBD with a very low THC, or it'll do the opposite and make a high THC with a low CBD, or it'll use 50-50 of its energy and roughly make about 1-to-1 in terms of equal strength of CBD and THC. And then to further complicate it, we can divide all of those strains into either what we call sativas or indicas, and this is really an outdated nomenclature, but it's the best we have right now. And sativas tend to be energizing and indicas tend to be sedating, but that is just anecdotal. And with time, it's going to really shift to limonene-rich strains or myrcene-rich strains or beta-carophylline-rich strains, and then we'll understand how those strains affect specific conditions better. So I don't have any affiliation with this company, but I just wanted to bring up some products just to show you a sense of what it looks like when patients go online and order. So these are 3 typical oils you'll see. Starting on the left there, that would be a high THC oil, and it lists, and it's hard to see, and I apologize, but it does list the concentration of 25 milligrams per mil of THC. And then the middle product is a 1-to-1, so that's 12.5 of CBD and THC. And then the last one is a high CBD, which is the reverse. It's 2 milligrams of THC and 25 of CBD. The other issue is that this is typically not covered, so it gets expensive fast for many patients. And then if you look at the dry flower on some of the websites, it'll tell you, again, the THC and the CBD, it'll tell you the cost per gram. And if you actually click into them, they'll give you a lot of information on the genetics of it and the different ingredients that they're measuring. They're not mandated to do that from the government, but they do that because it's contributing a little bit, I think, to the science. So a little bit about prescribing. So there is very limited guidance in how to prescribe medical cannabis, and nobody's really come out with a good document or guideline to say, okay, this is how you do it. The reality is it's an art, and it's really based on expert opinion, and you just have to treat dozens and hundreds and thousands of patients until you start to pick up patterns and develop an approach. And that's the current state that we're at until we get more science. The reality is cannabis is still reserved mostly for treatment-resistant cases where pharmaceuticals aren't working. The reality is that we do what we do with many medications. We start low, we go slow, we attempt to achieve the lowest effective THC dose. So we want to have patients achieve physical benefits without cognitive side effects. So the goal is not to have cognitive impairment. I would say that that is a recreational goal typically. Unless you have like post-traumatic stress disorder and you're just remembering the war, then maybe a little bit of amnesia goes a long way. So cannabis is not toxic. You're not going to get respiratory depression or death from consuming, but there are harms to it. The biggest risk is with THC. So we talked about, again, how safe CBD is and how it does not cause a lot of the side effects, typically very minimal side effects. But THC can cause tachycardia, it can cause anxiety and paranoia, and it can cause hallucinations. The number needed to harm in some of the literature is 1 in 23,000, and that's a very debatable number, but a lot of recent guidelines come out and they include sensory changes in the hallucinations group. I would consider hallucinations to be very different than sensory changes. I think if any of us took a big breath or went for a long walk and had our own endogenous cannabinoid production, we would all have sensory changes. So I think that's very different than hallucinations. So if you are reading guidelines, I would just be cognizant of that. Dizziness and transient amnesia are also potential side effects. These side effects can be minimized or avoided if you titrate slowly and patients follow a titration schedule and they just adhere to that. Patients who don't follow it are the ones that typically get some adverse events. Naive users, so patients who have never used cannabis, and I would tell you that 70% of the referrals that we receive are for patients who are not using cannabis or have never used cannabis or used it in the 60s, but it doesn't count because it wasn't your grandma, it was your grandma's cannabis. Much less potency. So we start them exclusively on CBD, high CBD products. And that way we can kind of get them acquainted to it, get them into using it frequently and feeling confident in using it. You'd be so surprised how anxious some people are about using cannabis, but they have a fentanyl patch on their back. And so sometimes reality is very different for so many patients. And with a cannabis, it's the reality and beliefs and the spectrum of beliefs is all over the place. And so it's really interesting to try to find that middle ground and explain, well, this is what we know, this is what we don't know, this is where we're researching, this is what I think it can do, this is what I think it can't do. So that's an art as well. The average script across Canada is 2 to 3, yeah. It will be across Canada very soon. 2 to 3 grams a day. Interestingly, in our clinic, the data is actually under 1 gram a day, and maybe we're just a little bit more cautious prescribers, or we do a lot more education and counseling. But so we're substantially lower clinically, but across Canada, it's 2 to 3 grams a day. We usually start like a naive patient on 1 gram a day. And that will allow them to order a mix of flowers and oils. So indications and contraindications. Again, there's not really an indication for cannabis. It's just some evidence supports its use, and we talked about the 3 or 4 conditions that it may help with. The contraindications to using THC typically, and mostly CBD kind of gets lumped into cannabis a lot. Very rarely do you see media or medical organizations make a distinguishing features between THC and CBD. So we're not actually getting an accurate picture unless we talk about these separately. So THC should not be used in breastfeeding or pregnant people. We know that it leads to potentially to, I believe, IUGR and increased NICU visits shortly after birth. I don't know if the data is exceptionally good for that, but nonetheless, given that there's potential harms, we need to be cautious. History of psychosis, schizophrenia is an absolute contraindication to THC. Recent MI, stroke, severe coronary artery disease or vascular disease. No one knows what the right timeline is for this, but typically we say within 3 to 6 months, probably should avoid THC. Under the age of 25 is a relative contraindication. We do have concerns that what is cannabis THC doing to the developing brain. There are studies showing some frontal lobe changes in recreational users. So we don't fully understand that, and there was new data just published last week showing that maybe some of the harms we thought in under 25 are a little bit over-exaggerated because the data was only analyzing cognitive outcomes within the first 48 hours of cannabis use, and it takes 3 or 4 days sometimes to wash out. And when they only analyzed the data after 4 or 5 days in the washout, all of those cognitive and IQ deficits actually disappeared. So we don't have a clear picture on that, but again, do no harm first, so we should be cautious until we have better data in that age group. And then if you have a substance use disorder, that's a relative contraindication. I do a lot of opiate reduction. I do a lot of benzodiazepine reduction. We're doing a prospective trial right now on 1,000 patients, looking at what quality of life and opiate changes we get when we substitute cannabis. A lot of them do already have an opiate use disorder, so I don't think it's fair to exclude them if the goals are harm reduction. So the third question, and the last one, which of the following is false? A, do patients require authorization from physicians or NP for medical cannabis? B, authorizations require the daily amount and length of authorization. C, cannabis products can be distributed via dispensaries. D, THC limits are suggested by the college but not required. E, edible products such as gummies, candies, and chocolate bars are not legal.
I see.
So again, the question was which of the following I think is false? The answer was C. So you cannot dispense cannabis through a dispensary. All those gummies and edibles, those are in a grayish, blackish market. And all of those people are going to face immense fines coming legalization. Oh, look, all the answers are now C. Cheaters. Okay, so it has to be distributed through the mail, through the licensed producer system. Okay, script and clinic operations, just a little background about what goes on in these cannabis clinics. At least our clinic, not all clinics are created equally. So patients go through a treatment agreement. It is still considered a narcotic, at least the THC is. So we have them sign a treatment agreement about how to use this properly, not to use street drugs, and when we would stop prescribing based on some things that they do that we don't consider ethical. We talk about driving safety. This is based on Health Canada's guidance, and they say if you're inhaling, you shouldn't use cannabis for 4 hours, maybe even 6 hours if you get euphoric or high. With ingesting oils, it's a little bit more complicated. The effects can be much longer. It could be even 8 to 10 hours. If patients are on CBD oil and they feel fine, I typically say, as long as you're not sedated, I'd give you the same advice if you took Benadryl. If they're taking THC products, then I advise them, there's a greater risk of impairment there. But to put it into perspective, being high on THC increases your risk of car accidents by 2 to 3 times. Legal alcohol driving at 0.05 is 7 times the risk of a car accident. And texting and driving for a car accident is 18 times. Okay, so just to put into perspective, we're being, I think we're being excited about cannabis, and there's a lot of people that really want safety, and I think as physicians, obviously, we advocate for that, but the science behind it also shows there's a lot of other harm from a lot of other things people are doing behind the wheel. And maybe we should have a more broader discussion even about pharmaceuticals, because I get worried when patients are taking Zopiclone, Ativan, and gabapentin and getting behind a wheel or driving the TTC, and then they're sending me a note asking me why I'm giving them CBD oil, and they're gonna fire them or lay them off. So there's a lot of science that needs to be done around driving, that's for sure. We talk about smoking harms, we don't advise it. And then the reality is we talk about the long-term effects. We don't have good long-term data on cannabis. We don't know if this is going to be good, bad, medium. So we just advise patients that as long as they understand and feel comfortable with that risk. The 3 documents are the signed authorization or prescription, amount to be used daily, THC limit, and then you send them to a licensed producer and you pick a company and they go to it, or the patient picks a company and they go to that one. This is what a prescription looks like, and I'll just briefly walk you through it. Patient identifiers are there. The amount used per day, so 1 gram a day is here. The length of the script, it says 3 months there. The THC limit is not enforceable ridiculously. Most companies oblige. There are a couple companies that don't, which is ridiculous, but it's not actually mandatory to write it on the script, but CPSO recommends it. The products that you want them to access. So if you wanted a patient to not be able to inhale, you could just put oil, or you could put urban oil if you feel like they need both long-acting and short-acting. And then just your information and your CPSO number in case you're going to get in trouble. And then you have to sign it. So prescribing tips, and this is really just based on my experience and having trained about 20 doctors across the country now and done this for a few years. Typically, physicians and patients prefer the oils, and the oils have only been available for 18 months. And the reason why we prefer it is because we can measure the dose and try to get a predictable effect. Putting 1 gram of cannabis at a certain percentage in your vaporizer, I don't know how many milligrams that is, and based on your lung volume and all these other variables, we don't know. So oils are preferable, but they're not for every patient. In my experience, I usually start with a lot with CBD, and probably 50 to 60% of our patients are on CBD exclusively. So we start around 5 milligrams twice a day, and we slowly titrate up slowly every day or two to about 60 milligrams. And you can go higher. You can definitely go to 100. And in the literature, right now they're studying 1,000 milligrams in Israel for psychosis, for CBD, as a antipsychotic. And they show that it's safe, but the reality is over 100 milligrams starts costing you $800 a month. So very few people can afford it. So I titrate up to what is essentially an affordable amount for now until coverage comes through. And I would say that the average patient, nonetheless, is somewhere between 25 and 50 twice a day for CBD oil during the daytime. The evening, I usually will add a little bit of THC product for patients to help them with relaxing or pain, or help them ease into the evening to help with sleep. And I usually start as low as 1 or 2 milligrams of THC. And if you look at the black market and you looked at what a gummy or a chocolate bar would be, that'd be like 100 milligrams. So that is the difference in medicinal and recreational. It's the dosage. An average THC dose for most of my patients is 5 to 20, and I would probably say that captures about 80% of my patients. There are 20% of patients who have been using cannabis for a really long time or have a myriad of complexity of diseases, and they use much, much higher doses regularly, and they don't get severe side effects even at the 1, 2, 3, 400 milligram range. But it is still pretty rare to have that high of a dose. If for some reason the CBD is not effective for my patients, regardless of the condition that they're using, then I'll introduce a little bit of the THC with the CBD. I very rarely use just a pure THC oil. I usually use CBD and THC, and the reality is having CBD with the THC will mitigate some side effects. It gives you more leeway to minimize side effects. And then dried flower, I'll authorize that for patients for breakthrough symptoms, or if they have conditions where they feel like ingesting the oils may not be of benefit. And so I kind of go through that protocol with every patient, and that I think allows us to achieve the most amount of successes. Cannabis does not work for every patient, and it's unfortunate because I do see people typically at the end of the line where they feel like there's no hope left. But we do our best to help patients. So I'm going to go back to our cases. So this was Susie with neuropathic pain. She was a 75-year-old lady who had exhausted all therapies. She was cannabis naive, so she never used cannabis before. So she was started on a CBD oil twice a day, and then we used a 1-to-1 oil at night. And then she reported that she had about 50% improvement in her pain symptoms. Her sleep was remarkably better. And she was on a dose of about 40 milligrams of CBD twice a day and 10 milligrams of the THC and CBD at night. Despite this, she still felt like there were periods where the oil wasn't cutting it and she still had breakthrough pain. So we taught her how to vaporize at the young age of 75. And she finds that that's very helpful for her breakthrough pain. And on her follow-up, she felt like that was quite better. Maggie with insomnia, so she was a 30-year-old female who had cervical cancer. She had exhausted a lot of therapies for insomnia, so we tried her on that 1-to-1 oil at night about an hour before bed, and it was very therapeutic for her. And for her dose was a little bit higher, about 15 milligrams. We added on vaporized cannabis because she felt like she couldn't initiate her sleep, and so sometimes using a fast-acting will help with initiation, and then a long-acting will help with prolonged sleep. And so she was reported a benefit. And then the last case, so this was Rebecca with ovarian cancer, who's spending a lot of time on the internet, who really just feels hopeless and is looking for a Hail Mary. And I empathize with the frustration that some of these patients have when they feel like there's not much hope. So nonetheless, she came to me and was optimistic that I could somehow cure her cancer. And she went on the internet, and this is what she saw. She saw that this lady claims cannabis oil cured her terminal cancer. And she saw that the grandmother who had a 33 millimeter tumor says it blasted her tumor with cannabis oil. And the famous case in the UK of a teen boy who was told to go home and die, and he had 5 days to live, and now he's thriving and living, and the mom is illegally getting cannabis oil for her son. I think it was a lymphoma he had. So, and then there's the opposite side of this, where the FDA comes out and says, look, you can't say that cannabis cures cancer. That's ridiculous. So it's confusing, and patients don't know what to believe, and patients are easily persuaded, and when you're hopeless, you're also easily convinced and persuaded. So what do we do for these patients? We try to help them, but we try to present evidence and explain to them what we can and can't do. So the reality is there is animal studies, and they do show that both CBD and THC have selective effects on cancer cells via apoptosis or suppression of angiogenesis via certain tumor cells that have CB1 and CB2 expression. There is zero high quality or even low quality research studies in humans. So we don't know if cannabis will help, but if you talk to patients who have claimed to have cured their cancer, or if you go on the deep web on the Facebook groups where people are doing this, what they're doing is they're using huge doses of THC, and they're slowly building up a tolerance, and they're claiming that this is helping their cancer. And we don't know because we don't have any of this evidence. There is a phase 2 and moving into phase 3 trial for glioblastoma multiforme, and there was 2 groups in that trial, and it looked at chemo plus the 1-to-1 oil versus just chemo, and it had quite a profound longevity outcome with the group with cannabis, but the reality is that's just a phase 2 trial. And so this is what I tell patients. I say, while cannabis does have perhaps some anti-cancer properties, so do blueberries and broccoli, and it doesn't mean that if you consume these products, it's going to help with your disease. And the reality is we don't know what ingredients would work. We don't know what dosages or what protocols we would use. And the reality is the evidence only supports using it for symptoms, and using cannabis, especially using it only on its own, could actually lead to substantial harms. So that's typically the conversation I have with them, and I say, if you're looking to alleviate your symptoms, I can help you. But if you're looking to treat your cancer, I'm not an oncologist. I can't help you with cannabis. And then patients, reality is I treat many palliative patients. I treat many patients with cancer, even in their early stages, and a lot of them still die from their cancer disease. So it's not that easy that the media likes to spin. But yeah, a lot of more research is going to take place in this, and if you look at the patent system, where the companies are filing patents for cannabis and cancer, it's really interesting to see where 5, 10, 20 years from now, where we may be headed. So yeah, I would just encourage you to be open-minded and to look into that and to see how it evolves over time. I do think it will change. So Rebecca came in, we agreed that we would treat her symptoms. She got the speech about broccoli and blueberries and cannabis. We started on her 1-to-1 oil. She did find that it was helping with her symptoms. We did authorize her to vaporize as well for breakthrough symptoms, and she felt that was helpful. She reduced her opiates, which again she felt was a goal of hers. 1 month later, I did receive a call from her children that she did pass away peacefully. And that's it.
Thank you. Thank you very much, Dr. Verbora. Does anybody have questions?
Yeah, thanks. That was very good. My question is there evidence for either psychological or physical dependence addiction to this? So, you know, a lot of these patients are palliative, and it's probably irrelevant, but maybe the patient that's not palliative, that maybe we don't see, or maybe they're on chemotherapy in an adjuvant setting and using it for symptom control. You know, is there issues with respect to physical or psychological dependence?
Yeah, there definitely is. The data from, I think it's the National Institutes of Drug and Safety, it's all the way back in 1994, quoted dependence around 9 to 11%, which is in line with caffeine, which I have a dependence on. There is definitely dependence there. I do see it in a small number of patients. I just don't feel it's as profound compared to typically the drugs that I'm trying to get patients off of. I'm dealing with a lot of opiates and benzos, and the potential consequences of those withdrawals or the dependence on that tends to be quite severe. And the reality is I think it's also overdiagnosed. I see a lot of patients who just admit to using cannabis, and right away on their CPP it will say cannabis use disorder. But if you really dive in, like, they're functioning well, they're getting to work, they're doing their job. So a use disorder has to be substantial impairment in day-to-day functioning. It does happen, it's just not that substantial.
Thanks. That was an excellent talk. Thanks. Personally, I am more open to the notion of cannabis products for patients that I'm treating as a supportive care measure, yet don't necessarily have the knowledge base to really guide them. So what I've been doing is to refer them on to cannabis clinics like the one that you have. I guess the question, moving forward is because there does seem to be a lot of art in the adjustments, and I think that from my vantage point, with it being a natural health product and not a pharmaceutical, the whole issue of how they get them and what the reliability of that's the concern that I have. But people that are prescribing this more would have more insight into it. Mm-hmm. So moving forward, do you think that that's the best strategy for patients, to have them referred to specialist clinic? And then I guess secondly, when this becomes legalized, and then patients don't have to come to me or to you, and they just kind of go get it. Is that model of care going to change? Mm-hmm.
Yeah, those are excellent points. So I think as we get more and more standardization and more evidence that says, and we do have capsules, for example. There are capsules available in the market, which I didn't talk about because they're relatively new. As we start to get more evidence, I think you'll see more practitioners come on board. But for perspective, there is 10,000 physicians across Canada prescribing cannabis now. So as we get more evidence and we have specific standardized products, I think there'll be less need to refer out for specific conditions. In terms of the legalization coming online at some point this year, the government has listened to all the vested parties, I guess you can say, and they've decided for the next 5 years to keep two streams, a recreational stream and a medical stream. And you have a number of companies looking to also distribute the cannabis through pharmacies and to try to normalize this like a normal medication, which I think is very helpful for patients. And then you have a number of insurance companies also coming in looking to cover this because they're seeing perhaps economic benefits by the reduction of other expensive pharmaceuticals. So I think if all of those areas pan out, and we don't really know how it's going to go, there's still going to be a huge need for some type of expertise. Will it still be in a dedicated clinic setting? I'm not too sure. But I do know that if you're going to get your cannabis covered, they're going to, the insurance companies are going to want you to be seen at a reputable clinic that have protocols in place, that have some evidence or some data. So I think it'll be more higher quality clinics, and it'll be much more streamlined.
Thanks for the talk, Mike.
Okay. How's it going?
Not too bad.
Yeah, long time no see.
Yeah, I know, right? My questions are on cyclic vomiting syndrome. Something that's sort of being postulated in the recreational cannabis users. Have you seen it in your patient population, either with THC-based products, and do you have any advice on treatment? Yeah,
so I've seen one case out of about 3,000 to 4,000 patients of cyclic vomiting in a medical patient, and we stopped and it got better, and then we waited 6 months, put them back on it, and like even at a low dose, it came back right away. So the answer was we had to abstain. I think the Emerge docs see it way more than I do, and maybe some of the patients aren't coming back to report it to me, so I may have biased numbers there. It is definitely an issue. It tends to be with high THC recreational users. I'm not too sure if the incidence of it is going to substantially increase with legalization, but it is an issue, and abstaining is the only solution to that problem. And we don't understand why some people get it and some people don't.
Okay, thank you.
Cyclical, it's called cannabinoid-induced hyperemesis syndrome. It's like a cyclical vomiting syndrome. Patients wake up every morning, they vomit, vomit, vomit. They have to take hot showers and baths. There's perhaps like a histamine-related response there to feel better. And a lot of them have poor insight into the fact that cannabis is the causative agent because they're using too much of it.
That was a great talk. Quick question. In Quebec, we're told that before we send our patients to the cannabis clinics, that they had to have actually tried this synthetic, and usually it's nabalone. So the question becomes, if we instigate the nabalone and it's not effective, I mean, is there still good evidence that we should send them on to the clinics for?
I would, because the synthetic is only THC, so there's no CBD content in it at all. So it's almost missing 50% of the products. But the other reality is I would just ask and pause and say, are there any other drugs or therapies that you prescribe where somebody tells you must try A, B, C, D before you can do anything, or can you use your clinical judgment? So just to put it into perspective, right? But yeah, nabalone I find is typically sedating and groggy for many patients. And so in my experience, when I transition them to cannabis, especially some that have CBD in it, they tend to do a little bit better.
I'm thinking more about, we have a lot of patients with neuropathic pain, and yeah, they get a lot of Lyrica and so forth. And, we have the data to show that if the patients have severe symptoms, then maybe some of these other agents, Lyrica, may have some benefit.
Yeah.
But most of them just feel very groggy and don't derive benefit. So, in order to help sort of, I think, older patients feel safe, I guess they feel that if a doctor is prescribing it to them in a pill, they kind of feel better about it. Has the nabalone itself shown to be very helpful for the neuropathic pain?
Neuro, I think the studies are all pretty small. Nabalone's really been studied most in chemotherapy-induced nausea and vomiting, and despite the fact that it doesn't have a lot of evidence in pain, and the herbal cannabis actually has more, if you look at like the new opiate guidelines and the new guidelines coming out, they still recommend using nabalone off-label, despite even having lower evidence than the actual herbal cannabis. But it is used off-label all the time for pain. I have anecdotes of patients that do better on nabalone for pain, but it's not good evidence-based.